All right, Ninja Nerds, in this video today, we are going to be talking about heart murmurs. Lots to talk about. And if you guys actually enjoy this video, it makes sense, we have a good time together, please support us. Hit that like button, comment down in the comment section, and most importantly, subscribe. Also, if you want some amazing notes, illustrations to follow along with to enhance your learning during this process, go down in the description box below. We'll have a link to our website. You guys can check that stuff out. All right, let's dig into heart murmurs. When we talk about heart murmurs, we should actually, but first, before we start actually talking about the different types of heart murmurs, and dive right into it, we got to actually start off a little slow and talk about how do actual murmurs develop. What's the physiology behind murmurs, right? That's a simple thing. And it's actually relatively straightforward. There was a guy, he was involved in the physics behind things. He talked about something called Reynolds number. Reynolds number basically, in the simplest way of thinking about it, Reynolds number, which you can represent as R with lowercase e, the higher the Reynolds number, the more turbulent the blood flow. And the more turbulent the blood flow is through a particular channel of like an actual vessel or through a particular small valve orifice, the more turbulent the blood flow is through that particular area, the more murmur that you'll have, right? So the more there'll be a murmur, an increase in the actual murmur. So that's really where we get these actual heart murmurs, is really from the turbulence of blood flow. So we have to think about what are the things that can actually increase the Reynolds number, because if we increase the Reynolds number, we increase the turbulence of blood flow through a vessel, through a valve orifice, through a particular area. And if we increase the turbulence through the area, you bring about a murmur that we can hear. What are the things that increase Reynolds number? So the things that we can increase Reynolds number is going to be one thing, velocity. So whenever you have a higher velocity of blood flow, this can increase Reynolds number. And what could be reasons by which we increase velocity of blood flow? One is that you're having the heart, in this case, really contract hard. So it can be situations where you have very high contractile strength. And we'll talk about some scenarios by which there's a really intense high contractile strength, the hyperdynamic activity of the heart. The other thing is whenever there's small diameters. So decreased diameters of small valve areas or small vessels where you have to squeeze a ton of little blood through. The smaller the diameter, the higher the velocity of blood flow through that particular area. So these would be particular things that will increase the velocity and increase the Reynolds number. And if you increase the Reynolds number, you increase the turbulent blood flow and cause murmurs. All right, that's one thing. The second thing that we actually have to talk about is viscosity. So viscosity is actually interesting because it's inversely proportional to Reynolds number. So in other words, if we want to increase Reynolds number, we would need a lower viscosity. So lower viscosity of blood, meaning there's less particular formed elements like red blood cells and platelets and things like that. If there's less red blood cells, which are the main component of our blood, one of the main components, if there's less red blood cells, there's more of the plasma to run around. And there's more of an opportunity for turbulence of blood flow. There's more space for blood to actually flow. And so decreasing the viscosity definitely will increase the Reynolds number, increase the turbulence, and precipitate murmurs. What are situations by which the blood viscosity is low? Anemia, and we'll talk about that. The next thing that I want you guys to remember is that there's actually something that's not dependent upon Reynolds number, has nothing to do with it. And it's actually when there is blood flow. So there's one is an increased velocity, decreased viscosity for Reynolds number. This last situation has nothing to do with Reynolds number. It's actually blood flow across an incompetent valve. Whenever blood flows across an incompetent valve, it creates a significant turbulence of blood flow, enough to be able to precipitate a murmur. And that's the big things I want you to remember. So there's an increase in velocity, a decrease in viscosity, or there is something that has nothing to do with Reynolds number, which is blood flow across an incompetent valve. Let's talk about the things that can actually cause this, because then we can understand the physiology. So let's actually talk about the first category, which is velocity, but particularly those things that increase velocity with respect to diameter. So small diameter, channels, small diameter valves, all of these situations. Well, one particular situation is, there's a condition called a ventricular septal defect. Ventricular septal defects are really interesting. So ventricular septal defects, whenever your left ventricle, it's a higher pressure system, when it contracts, it's going to want to push blood from areas of high pressure to low pressure. So normally it would want to go into the aorta. But there's also this channel here, this septal defect, by which blood can jet across into the right ventricle, right? That's one particular thing. This is called a ventricular septal defect. Now, here's why I want to mention this, because it has something to do with the intensity of the murmur. The smaller the diameter, so the smaller the VSD, that would mean that the smaller the diameter of the ventricular septal defect. The smaller the diameter, the higher the velocity. So this would cause a higher velocity. And the higher the velocity, the more turbulent the blood flow. The more turbulent the blood flow, the higher intensity the murmur. That is one of the big things to remember. And it's very interesting because oftentimes when we think about ventricular septal defects, we would think, oh, the bigger the septal defect, the worse the murmur. It's actually opposite. The smaller the defect, the smaller diameter, the higher the actual pressure gradient across these, and the higher the velocity across that area, it's going to intensify the turbulence of blood flow and increase the intensity of the murmur. So don't forget that. Okay, so VSDs, particularly smaller VSDs, that's one particular reason that can cause turbulence of blood flow. Here's another one. Another one is called a coarctation of the aorta. So we're going to put coarctation of the aorta. You know, coarctation of the aorta is when there's kind of this narrowing of the aorta. Usually there's different parts. It could be before the left subclavian vein, before the left subclavian artery or after the left subclavian artery. We're not going to get too much into that. There's just a narrowing of the aorta. If there's a narrowing of the aorta, whenever blood flows from the left ventricle into the aorta, now it has to squeeze through that tiny little diameter portion of the aorta. That's a small diameter. That small diameter is going to increase the velocity. So there's going to be a high velocity due to the small diameter, and that's going to cause an increase in the turbulence of blood flow and increase the murmur. That's another big thing. All right, what about another one? What if I have somebody who has aortic stenosis, or they have another situation here? Particularly if I have aortic stenosis, or if I have this big old thing here that's kind of obtruding off the septum. You know, if somebody has aortic stenosis, one of the things that you have a small diameter opening here that I got to squeeze all that blood through. That small diameter is going to cause, you're going to have to work really hard and push a lot of blood across that area. And whenever there's such a small diameter, there's a high velocity, right? So high velocity, and that's going to increase the murmur. The other situation is, what if I have this big old septum? So you have an asymmetric hypertrophy of the interventricular septum. And now I got to squeeze blood flow from the left ventricle through this tiny little area here up into the aorta. That's a small diameter. So in conditions such as hypertrophic obstructive cardiomyopathy, there is a very small diameter, and that can increase the velocity wherever that small diameter is and increase the turbulence of blood flow precipitating a murmur. So these are the particular mechanisms behind which these murmurs actually occur. So we have an increase in velocity due to a decrease in the diameter of the vessel, the valve, the particular orifice by which blood is flowing through. Now, when we talk about viscosity, right, which is the thickness of blood flow, think about pushing molasses versus pushing water, right? Molasses is going to flow really slow, right? So if it's really slow, that's not going to give you a lot of turbulence of blood flow. But if you have kind of a thinner type of substance that you're moving through a vessel or through a channel or through an orifice, it's definitely going to give you more flow, more rapidity of the flow, more turbulence of the blood flow. It's a simple concept, right? So what we want to think about is when there is a reduction in the viscosity. So something that's going to make the blood a little bit more watery, not have as much components or solutes to it that are going to make it more thick and sticky. In that situation, the things that would actually decrease viscosity, you'd want to remember as anemia. Okay, and again, it's a pretty straightforward concept that as we think about from what we've established from the relationship below, a decrease in viscosity is going to increase the turbulence of blood flow. So decreased viscosity will do what to the actual turbulence? It'll increase the turbulence. And I just think about that example of pushing like something like water versus like molasses through a small channel. Which one's going to move faster? The watery substance. That's one thing. The next thing is, let's go back to the velocity really quick. So velocity now, we said it could be due to a small diameter by which I'm going to push a ton of things through, or it could be something that's really kind of like I'm generating a lot of force. So if the origin of where all the blood is coming from, if the strength by which that origin is contracting and pushing the blood through, that higher force is going to have higher velocity through those channels and orifices and small areas. So I have to think about things that will increase the contractility of the heart. Anything that increases the contractility of the heart is going to increase the force by which we're going to push blood, and that will definitely increase the velocity of blood through these different types of channels. That'll increase the turbulence, and as you increase the turbulence of blood flow through these channels or through these orifices or through these particular areas, that will definitely give you these murmurs. So the question that we have to ask is, what are the things that can increase the contractility of the heart? Let's come down and think about this. Things that would increase the contractility of the heart, what would that be due to? Well, we got to think about this. What would cause the heart to just clanging and banging and going crazy and pushing hard amounts of blood out of the left ventricle? So the left ventricle is just slanging, it's banging, and it's pushing this blood out of the heart into the aorta, okay? When this happens, we need situations where there is a hyperdynamic heart. What are the situations by which we can have a hyperdynamic heart where it is just really pumping hard? These would be things that are driving the sympathetic nervous system of the heart. So things that are increasing the sympathetic nervous system of the heart. This could be due to exercise. This could be due to fever. This could be due to sepsis. You know what else it could be due to? Certain situations where there's an increase in the amount of thyroid hormone, increased levels of T3 and T4, such as in thyrotoxicosis. You know what else it could be due to? It could also be in situations where there's higher volume states, where you're having more volume, more preload, the heart's contracting harder. This could be in situations such as pregnancy. And another thing is anemia. Anemia can actually cause higher contractile states. There's other things that can cause high outflow states. So high outflow states could be things like, these are a little bit more uncommon, but anemia, beriberi, which is actually going to be due to a thiamine deficiency, or AV fistulas. These actually generate higher outflow states. Your heart has to work harder to keep pumping blood out into the circulation. So these are some of the things. There's a lot of things that can create these hyperdynamic hearts, which increases the contractility and causes higher amounts of velocity, more blood flowing through these channels, through the valves. That's going to create particular turbulence and murmurs. These are things to think about. Okay, last but not least is going to be something by which we said has nothing to do with Reynolds number. It's actually more particularly, it's kind of an isolated entity. And this is going to be when there is blood flow across incompetent valves. What kind of situation by which you would have these incompetent valves, meaning that they're not providing a good flow? That's pretty straightforward, right? Let's say here is your aortic valve. It's not doing a good job being able to prevent backflow into the aorta. What is that called? Oh man, these are pretty easy, right? Aortic regurgitation. You have this valve here in the pulmonary valve. It's supposed to prevent backflow. It doesn't. This is called pulmonic regurgitation. You're supposed to have this valve here, which is supposed to prevent backflow into the atria. It doesn't. This is called mitral regurgitation. And then last but not least, this valve is supposed to prevent backflow into the right atrium. This is called tricuspid regurgitation. So any of these situations by which there is blood flow across incompetent valves really kind of put you in a category of any regurgitation murmur, because that will actually push blood back into, so for example, think about blood coming back into the pulmonary, from the pulmonary trunk into the right ventricle. When it flows across, it's going to bounce off the walls here and produce turbulence. That is a turbulence of blood flow, right? It has nothing to do with the things that actually affect Reynolds number. It's just there's going to be turbulence of blood flow. And that's because whenever the blood is backflowing, whether it be from the pulmonary artery into the right ventricle, aorta, into the left ventricle, it's going to bounce off the walls and create a turbulence of blood flow. So that is the concept here. It's going to hit off these walls and produce this turbulence. That's going to give you a sound, and that sound is going to be a murmur. So that's the big things to think about. All right, we done talked about the physiology of murmurs, which again, all comes down to the turbulence of blood flow, which is dependent upon the Reynolds number. In those situations, we said increased velocity from hyperdynamic states or from small diameter orifices or channels will increase the turbulence via the Reynolds number. Or a decrease in viscosity will cause the blood flow to move faster, increasing the turbulence. And last but not least, something that has nothing to do with the Reynolds number, but whenever there's blood flow crossing a incompetent valve back into a chamber and the blood is bouncing off the walls of those chambers, it creates a turbulence of blood flow and precipitates murmurs. We now understand that. Let's go and talk about some characteristics that we need to understand about murmurs now. All right, so let's talk about now the next thing. There's a lot of things up on the board. You're like, oh my gosh, there's like a million things that we have to go over. Don't worry, I'm gonna make it really simple, because when we talk about murmurs, we have to come up with a system to be able to remember a lot of these. It's difficult, I'm not gonna lie with you. I have difficulty in being able to remember all the different terms and buzzwords that we have to be able to utilize for our exams. But I think I came up with a good way for you guys to easily categorize these in your head and remember them. So what I wanna do now is I want to talk about a couple things all in one area here. So I want to talk about, when we're talking about murmurs, we understand the physiology behind them. I want us to know now where, if I have someone who has aortic stenosis, aortic regurgitation, yada, 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 Where am I listening on the chest? That's the first thing, so location. Second thing I want us to talk about is that some murmurs, it is super important. It helps you to differentiate from other ones based upon where the murmur radiates, which is dependent upon the path by which the blood is flowing. And we'll talk about that. Then after we talk about that, we'll go over the quality. There's particular buzzword terms that we utilize to describe a type of murmur. Is it blowing? Is it machine-like? Is it harsh or rumbling? So on and so forth. Then we'll get into pitch. So pitch is important because it determines if we listen with the bell of our stethoscope or the diaphragm of our stethoscope. And we'll talk about that. And then lastly, we'll talk about the intensity, grading the murmur, because that's going to have a clinical correlation associated with it. And a little tidbit that I want to teach you guys something that's very interesting. All right, so let's go through that. Location. Easy way to remember location is the step-by-step process. We're going to go in this order. All physicians earn too much. So aortic valve, this is going to be, you come down and you listen at the right second intercostal space, peristernal border. So there's our first rib, second rib, third rib. So it has to be right here, second intercostal space. So again, aortic valve will be at the right second intercostal space, peristernal border. Now, the next one is the pulmonic valve. The pulmonic valve is the left second intercostal space. Pretty straightforward, right? So here we have our left second intercostal space. And this is going to be peristernal border. Boom, we're nailing these. Erb's point. What the heck is Erb's point? Don't worry, we'll talk about what Erb's point is a little bit later in these. We'll talk about why we're listening at these areas and what we should be listening for and types of murmurs that could be present in just a second. But Erb's point, just come down one more. So now we're at the left third intercostal space. So we're at the left third intercostal space, peristernal border. Then you come down again one more, tricuspid valve. So tricuspid valve is left fourth intercostal space, peristernal border. Man, this is not too bad, right guys? And then mitral valve, you would think, oh, we come down one more. Nope, got to trick you up a little bit here. We do go down to the fifth intercostal space, but we don't go peristernal border. We go at the midline level of the clavicle. So I'm going to drag this down here, about right here. That is going to be where I listen at the mitral valve. So I go left, fifth intercostal space, definitely, but it is not peristernal border. Now it's at the level of the midclavicular line. All of these above were at the peristernal border. That's a simple way to remember it. Now, why do I want to remember that? Here's why. If you're listening at the aortic valve, you're listening for things such as aortic stenosis, aortic regurgitation, and then also a coarcted aorta. All of these are types of murmurs that you want to be listening for. So that's where you'll be listening. You'll hear the best types of murmurs, particularly aortic stenosis, aortic regurg, and coarcted aorta at the right second intercostal space. Boom. What about pulmonic? You guys are going to be like, oh, this is so easy, man. This would be pulmonic stenosis, pulmonic regurgitation. And if you wanted to take it to the next level, we're not going to talk about this in this lecture, but ASDs can also be heard in this area, atrial septal defects. All right, Erb's point. You're like, dude, I've never even heard of this, bro. Don't worry. This is probably the most common area that most people listen to. They go to this area, they listen, because it's a good overview area. That's what I want you to remember Erb's point as. It's kind of called the cardiology point, because what we do is we take the stethoscope and I can hear almost everything I need to hear in that one point. And so it's good for being able to tell me your S1 and your S2. I should be able to hear both S1 and S2 in this area. And it gives me a bunch of different murmurs. The one that I really want you guys to think about though, it's pretty good in this area, is hypertrophic obstructive cardiomyopathy. So this is actually one that I would be listening for hypertrophic obstructive cardiomyopathy. Okay, tricuspid valve. If I'm listening in this area, what kind of murmurs, son of a gun, what should I be looking for? Obviously, tricuspid stenosis is an obvious one, right? So I want to listen for tricuspid stenosis. I want to listen for tricuspid regurgitation. And there's one more, the VSD, the ventricular septal defect. And then last but not least, the mitral valve. At the left fifth intercostal space, I'm listening for mitral stenosis, mitral regurgitation, and one more called mitral valve prolapse. That's why it's so easy. Once you identify the location, we'll go through all the different things that helps to distinguish all these different murmurs, but we know the locations now. That's a good thing, right? So we know the physiology, we know the locations. And they're actually relatively simple. The only ones that are a little bit funky is the ASD, the hypertrophic obstructive cardiomyopathy, and the VSD. All the rest of them make sense. So that's it. Radiation. Radiation is when you have this murmur, you want to think about the type of murmur it is, and it'll all kind of come together throughout the process of this lecture, but think about the path by which that blood is flowing within that murmur. So there's three that I really actually want you guys to remember that are most important. This is, first one, aortic stenosis, aortic regurgitation, and then we'll talk about another one here in just a second, which is called mitral regurgitation. These are the ones that I want you guys to definitely remember the radiation for because it's helpful. Aortic stenosis. The whole process behind aortic stenosis is there is a reduction in forward flow. The blood is trying to go from the left ventricle into the aorta, right? And then from the aorta, it would obviously follow up through the carotids and the arms, down the lower extremities, right? But the problem is when you're pushing blood out. It's a difficulty in getting blood out of the heart. So we would hear this where? You would hear it at the right upper sternal border, so right second intercostal space. So that's where you would hear it. But then when you're actually listening for the murmur, it's a problem where there's an issue with forward flow. This would radiate though, if you think about the path of blood where it's moving, it is moving forward, just very reduced. It's going to go up through your carotids. So it's going to radiate to the carotids. That's a pretty straightforward one, right? So it radiates to the carotids, and we'll put R for radiation. Okay, aortic regurgitation. And aortic regurgitation is blood is backflowing. So let's do this in kind of a different color here. Blood is backflowing from the aorta down into the left ventricle. Okay? It's coming backwards into the left ventricle. Think about this. Where do we hear this? We hear it at the right second intercostal space. We've already established this. But when it radiates, it's coming in the direction of the flow. So here, think about this. You have the right second intercostal space here. You're listening to the aortic valve. When blood is backflowing, it's backflowing this way, towards the left ventricle. That's going towards the left upper sternal border. So it's going to radiate to the left upper sternal border. We say maybe it's going to be like the pulmonic valve area or the Erb's point area. Those are generally where we're going to potentially hear it. So that's pretty cool, right? So the aortic regurgitation murmur is you're going to have it sounding at the right second intercostal space, but it will actually radiate in the direction by which it's flowing, which is back into the left ventricle, which is the left side of the heart, left sternal border. So that's important one to remember here, radiation. All right, mitral regurgitation. This is a problem where blood is supposed to be going from the left ventricle up into the aorta, but it's not. It's backflowing into the atria. So we would hear this where? You would hear this at the left fifth intercostal space, mid-clavicular line. But when it radiates, think about this. So you're listening here for the actual mitral regurgitation. When you listen there, it's going to be pumping backwards. Like it's actually going to be going this way. All right, pumping back into the left atrial. So imagine left ventricle here, left atrial here. It's going to be pumping this way. That's going into the axilla. And so if it's pumping backwards into the axilla, there'll be radiation of that murmur into the axilla. It's not so bad, right? So these are the ones that I don't want you to forget. Don't forget mitral regurgitation radiates to the axilla. Don't forget aortic regurgitation radiates to the left sternal border. And aortic stenosis radiates to the carotids. Boom shakalaka, we good. Okay, quality. Quality is a way that it's an annoying one. I think it's not like super important, but it's more of like a memorization point, unfortunately. When we talk about quality, it's a way that whenever they present these in the clinical vignettes, that they may use a very specific buzzword term. They may use the term called blowing, or a harsh type of sound, or a rumbling type of sound. And so when you are a musical or machine-like, and those all have particular pathognomonic types of situations, meaning that you hear that term, you think about this disease. And so we'll write these down so that you can remember them in case they pop up. They may help you to think about the type of murmur it is. So quality-wise, it's telling me the characteristics of the murmur. So the first one that I want you guys to remember here is going to be if you hear something called a blowing murmur, or we also hear the term sometimes musical. So blowing or musical, you want to think about the term aortic regurgitation or mitral regurgitation. Because blowing murmurs are usually regurgitation murmurs. Musical murmurs are usually regurgitation murmurs. That's the big thing to think about. The next one here is if a patient has what's called a harsh or rumbling type of murmur. So you hear that term, harsh or rumble type of murmur. This is particularly indicative of aortic stenosis and mitral stenosis. Okay, it's particularly indicative of aortic stenosis and mitral stenosis. Don't forget that. So again, you hear blowing or musical, you think aortic regurgitation, mitral regurgitation. You hear harsh or rumbling type of murmur, you think aortic stenosis and mitral stenosis. And correlate that also with the location and correlate that also with the radiation of the murmur. It's going to be relatively easy, right? We're getting there. The next one, which is the one that you definitely don't want to forget, because this will definitely be one that they present in your pediatric types of MCQs, is that if you hear the term machine-like, so machinery or machine type of murmur, this is automatically pathognomonic for patent ductus arteriosus, which is a hole that exists between, that's where there's a shunting of blood flow from the aorta into the pulmonary artery throughout systole and diastole, and it sounds like a machine that's going off. These are very important qualities of murmurs that we have to understand. So we got the location, we got the important radiation points, and we got the important qualities of the murmurs that are very important. All right, so let's talk about pitch. So when we talk about pitch, we're talking about kind of like, this is going to determine whether we listen with the bell of our stethoscope or the diaphragm of our stethoscope. That's kind of the big thing behind this. So when we talk about pitch, let's think about a couple scenarios here and what pitch actually really comes along with. It actually depends upon pressure gradients and volume of flow across a particular structure. When we talk about this first one, let's talk about a VSD. I think this is a really good example to start off with. A VSD is a very important one because when you think about the flow, it's going from the left ventricle over to the right ventricle, right? That's kind of the whole concept. It's a high pressure gradient. There's a high pressure gradient. So when there's high pressure gradients that are existing, this actually is going to give you a very high pitch. So whenever there's high pressure gradient, this gives you high pitches type of murmur. And high pitch murmurs are best heard with the diaphragm of the stethoscope. So that is a big thing to remember. Now this would be better, right? High pressure gradients, again, you're thinking about high pressure gradients. This could be with any kind of scenario, but I think a really good one to think about here is ventricular septal defects. So if ventricular septal defects, there's a high pressure gradient from the left ventricle to the right ventricle. But in any kind of scenario where that kind of pressure gradient exists, where there's not a large volume of flow across it, okay? So it's high pressure gradients with not a large volume, because you have a small septal defect, not a large volume of blood is gonna be flowing across that area. So it's primarily the high pressure gradient and not a large volume of flow. This is a perfect example. In those situations, they give you high pitches. Okay, best heard with the diaphragm of the stethoscope. Let's pick another example. Another scenario here where you're gonna want to think about is, let's say that you have somebody who has mitral stenosis. They got a really, really stenotic valve, right? So let's pick an example here of mitral stenosis. In mitral stenosis, they have this really, really stenotic valve, and what happens is your left atria is trying to increase the pressure to push the blood from the atrium into the ventricles, right, during diastole. But here's the thing, the left atrium is not a super high pressure system. It's gonna try to increase its pressure to push the blood down, but when you're going from an area of the left atrium into the left ventricle, in general, the pressure that you're gonna be able to generate in this direction isn't gonna be super high. So we consider this direction by which the flow in a murmur is actually being precipitated, we consider this to be a low pressure gradient. It's just not a high pressure system. Going from atrium to ventricles, in general, are a low pressure gradient. That's pretty common no matter what, right? That should make sense. When you go from the atria to the ventricles, that's not a super high pressure gradient. Now, when you go from the ventricles into the aorta or from the ventricles into the pulmonary artery, those are high pressure gradients, but going from the atrium to the ventricles are not high pressure gradients, they're lower. However, what we are trying to do though is the left atrial pressure will try to increase a little bit and increase the flow across that valve. So we are gonna try to increase the blood flow across that valve the best that we can. And so whenever there's a low pressure gradient in combination with a high amount of blood flow across that valve, because the left atrium is trying to increase its pressure to push the blood across that valve, this combination will give you a lower pitch. Okay, so this is going to be a low pitch because there's a low pressure gradient. And again, you're trying to get blood flow across that valve, but it's just not enough. In this situation, this is best heard with the bell of the stethoscope. So don't forget that. So when there is High pressure gradients, you hear it better with the diaphragm because it's going to give you a high pitch. If it's a low pressure gradient, even though there is trying to be more blood that's flowing across that valve by the left atrial pressure increasing, it's still going to be low pitch, and that's best heard with the bell of the stethoscope. The last scenario is in someone who has something called aortic stenosis. In aortic stenosis, in this situation, you have the left ventricle trying to pump blood into the aorta across this stenotic valve. If that's the case, the left ventricle, whenever it generates pressures to push into the aorta, that's a high pressure system. So that system, when you're having aortic stenosis, you're going to have high pressure gradients, super high pressure gradients. On top of that, think about all the blood flow that's moving across that valve. You're going to have to generate a lot of pressure. The left ventricle is going to have to generate a lot of pressure, increase its pressure more than usual to push as much blood flow as it can across that valve. And so there'll also be a very large blood flow across the valve. In that situation, the combination of high pressure and high blood flow is going to really, really increase the pitch to the point where we consider this to be more of a harsh terminology. We call it harsh, again, going back to the aortic stenosis. In those situations, this is again best heard with the diaphragm of the stethoscope. Okay? That is an important thing to remember. You may also see this in another situation, not just aortic stenosis, but what if the left ventricle is pumping tons of blood and a high pressure system from the left ventricle to left atrium? In that situation, that's a high pressure gradient, and on top of that, it's a lot of blood that's flowing backwards into the atria. You may also see this in mitral regurgitation, where you want to be listening with the diaphragm of the stethoscope. Or if the aorta is just tons of blood are backflowing in a high pressure system from the aorta back into the ventricles, that's going to be another situation. So you may also hear this in aortic regurgitation, thus supporting the fact that you should listen to this during what? With the diaphragm of the stethoscope. So these are the concepts that I want you guys to understand here, is that when we're looking for pitch, the big thing here is that if there's high pressure gradients, that causes a high pitch. If there's low pressure gradients, that's going to cause a low pitch. Again, if there's high pressure gradients plus a lot of blood flow across a valve, that's going to produce very high pitches, where we call that harsh types of pitches. Low pitches are best heard with what? The bell of the stethoscope. High pitches are best heard with the diaphragm of the stethoscope. That's simple. Okay. We got down location, we got radiation, we got quality, we got some of the pitch concepts that we have to understand. And really it just comes down to high pitch, diaphragm, low pitch, bell. That's it. Intensity. When we talk about intensity, this is important for grading a murmur. So we utilize this to grade a murmur. So we have grades particularly from 1 all the way to grade 6. And we say that generally the higher it goes, the worse the murmur. We'll say how that technically is true with a couple of exceptions. So how do we really grade these murmurs? So let's say that you're taking your stethoscope, you're listening to the patient's chest, you're listening for a particular murmur. Let's just say aortic stenosis. So you're listening here at the right second intercostal space, you're trying to listen for a second, and it's just really, really tough. It's super faint. There may or may not be a murmur kind of present. It's tough to say. So it's difficult. It's difficult to discern, let's say. Difficult to discern a murmur, okay? Very faint type of murmur present. That would be a grade 1. A grade 2 is where it's faint, but it can be heard. So it's faint, but it can be heard with careful listening. With careful listening, you listen a little bit, it's faint, but okay, I can hear that. A grade 3 would be it's super easily heard. Okay, you place the stethoscope on the chest and it's obviously heard. Oh, that's definitely a murmur. Okay, grade 4 is it's loud. It's a loud murmur. And they have, whenever these murmurs occur, sometimes it causes like a vibration of the chest wall, that whenever you put your hand or your stethoscope on their chest, you can actually feel the vibrations of the actual murmur against the chest wall. So they call it the thrill, the vibratory sensation. That is actually called a thrill, and sometimes that can be palpable with your hand or with the stethoscope. And so in these patients, grade 4, it's loud murmur, just like it is a loud murmur, but they also have a palpable thrill present. For a grade 5, this is super loud, and they have a palpable thrill. But here's the thing. You can put the stethoscope like just barely touching the chest, it's barely touching the chest, and you can still hear the murmur. If you have it on the chest and you're listening and you have a palpable thrill, and it's there easily, that's a grade 4. But if you have, let's say that you just pick the stethoscope a little bit where it's barely, the rim of the diaphragm is barely touching the chest wall, that could be considered to be a grade 5. Okay, so stethoscope, barely on chest. Okay, that's going to be considered to be a grade 5. And then grade 6 is where the dang thing is so dang loud, you have a palpable thrill, but on top of this, you can hover the stethoscope over the chest and still hear the murmur. That's insane. You're hovering over the chest and you hear that it's loud. You actually can feel the vibratory sensations with your hand or with your stethoscope off of the chest, and you can still hear the murmur with the stethoscope off the chest. That is a grade 6. This is how we would grade murmurs. Now, why is all of this important? Well, really what's important to remember is that we generally say, for the most part, that grade 1 to 3 are likely to be, there's a lower likelihood of pathological murmurs. So it's potentially more likely to be benign, okay? Whereas we say if it's grade 3 or greater, particularly greater than grade 3, so we sometimes kind of like have it right on that brink. So grade 3 and up, it's a higher likelihood of being pathological. So actually we should say this. Let's say grade less than 3 to be easy here. If it's less than 3, grade like 1, 2, it's likely to be more benign. If it's 3 or above, it's likely to be more pathological and need further evaluation. There's one little exception to this concept here, where the grade less than 3 and grade 3 plus, usually we say 3 plus, oh, it's pathological, grade less than 3 is benign. There's one exception, particularly to the grade less than 3. If somebody has a VSD, right? They have a VSD, we would say, which would be the worst case VSD? So if someone has a VSD and it's a small, let's put small VSD. That means a small diameter, right? A small diameter. If there is a small diameter VSD, that means that there's going to be a higher velocity of blood flow across that VSD. If there's a higher velocity of blood flow across that VSD, that's going to be a higher turbulence and a higher intensity of the murmur. So that'll increase the grade of that murmur. But it's a small VSD, so that's not as severe or pathological of a VSD. That would be an example. If you have a big old honking VSD, a large VSD, which is a bad situation, the murmur, what would happen to the murmur? A large VSD is a large diameter. That means a lower velocity, a lower turbulence of blood flow, and a less intense murmur. But it's still a very significant type of murmur. It's a pathological murmur. So large VSDs means worse pathology, but the intensity of the murmur is lower. Smaller VSDs means less significant of a pathological situation, but higher intensities of the murmur. So don't forget that as a particular exception here. Okay. Engineers, we've gone through the location, the radiation, the pitch, the quality. We've talked about the intensity. Now that we've gone through that, we've really covered this in depth. The next part is super, super important because we're going to kind of put a lot of stuff together. And that's talking about the timing of murmurs, if it's systolic, diastolic, continuous, and we'll use some particular types of murmurs. And then the configuration. Is it crescendo, decrescendo, is it holosystolic? All of these things, we're going to use all that terminology and keep kind of repetitively coming back and talking about location, radiation, quality, pitch, and intensity. Let's talk about that. All right, so let's talk about the timing and configuration of murmurs. This is a very important part. So we want to understand what happens, particularly, we understand if we're listening for a murmur at a particular location, we can obviously kind of identify, is this the aortic stenosis, is this aortic regurgitation, right? I can listen for radiation. I can listen for the quality, is it blowing or is it harsh? I can also kind of determine the pitch of it. Generally, both of those are higher pitches, so diaphragm's going to be better. And then I can determine the intensity. Is it grade 3 or above? Likely grade 3 or above because they're pathological. So with that being said, the timing and then the configuration of the murmur can also help me to differentiate them. So this is where systolic, diastolic, continuous murmurs come into play. All right, so when we talk about these, the first thing that we have to think about here is when the ventricles go through a particular stage, right? So we have the first stage that they'll go through, which is ventricular systole, right? So we'll have them go through the ventricular systole. They're going to start contracting. So when the ventricles contract, they eject blood out of the heart. right? And that would begin at what point? Well, we have S1, which is the closure of the mitral and the tricuspid valve, S2, which is the closure of the aortic and the pulmonary semilunar valve, and then back again here to S1 to start the cycle all over again. From S1 to S2 is the ventricular systole. So we would say from this point here to this point here would be systole. So this would be systolic murmurs. So this is where we're going to be talking about different types of systolic murmurs. And there's different ways that we can categorize systolic murmurs. We can categorize them into what's called early, we can categorize them into mid, and we can categorize them into holosystolic murmurs. And we'll go over all of those, okay? The next thing is we have, after ventricular systole, the ventricles have to go into a relaxation phase. So then they have to start relaxing and filling with blood. In this phase, this starts at S2. So then the closure of the aortic valve, the closure of the pulmonic valve, and only blood should be coming in from the atria. So this starts at S2 and then continues until you get to S1. That's ventricular diastole. All right, so this is going to be the diastolic murmurs, and we'll talk about the different types of diastolic murmurs that we have here, okay? So we have, again, ventricular systole, then we have ventricular diastole when they're going through relaxation. There's one more type of murmur category that we can have. It's not just during systole, it's not just during diastole. This bad boy occurs during the entire time period from systole and into diastole. What's this called? This is called a continuous murmur. Continuous murmurs. And there's really one that we have to talk about in that one, but we'll go over it, okay? So then you have the combination of ventricular systole and ventricular diastole that you'll be seeing these murmurs. Okay, so we got the different types of murmurs. Systolic occurring from S1 to S2, and then diastolic occurring from S2 to S1, continuous occurring throughout S1 all the way to the next S1. Let's talk about systolic first. So there's three different types of systolic murmurs. Early, okay, systolic murmurs, mid-systolic murmurs, and holosystolic murmurs. And we'll talk about what each one of those means. So early systolic murmurs, okay, here's the ones that I really want you guys to remember here. There's two particular ones that you guys can't forget here. The first one is called aortic stenosis, and we'll add in another one here called pulmonic stenosis. So there's stenotic lesions. The second one that I want you to remember here is called hypertrophic obstructive cardiomyopathy. And if you really want an extra one to add on here, you can even add in a coarctation of the aorta, can also cause this too. But I'm not super concerned about this one. I really want you guys to remember particularly aortic stenosis and hypertrophic obstructive cardiomyopathy. So what happens in these types of murmurs? Okay, whenever your ventricles are in systole, they're just starting their systole, they're getting ready to contract and push blood out of the heart. When they try to push blood out of the heart, in situations of aortic stenosis and pulmonic stenosis, the issue is with the valve. If I have somebody who has a very, very rigid and fibrotic type of calcified, immobile, not very pliable valve, and I have to try to snap that valve open. So another way of looking at it is, imagine here, I have this valve looking like this. So here's the one leaflet here, here's the other leaflet here, here's the opening between it. And what I want to do is, I would imagine that you guys would want the valve to open up like this during ventricular systole. Because if it's opened up now, it's easy for blood to flow through. That's not what happens. In aortic stenosis or pulmonic stenosis, what happens is these valves are rigid and not very pliable, so whenever the left ventricle contracts to push blood up, it actually causes these valves to bow like this. So now this is where they would actually look like during ventricular systole. So they go from here and bow out like this. And that bowing of the valve produces a very interesting characteristic clicking sound. Okay, so imagine left ventricle contracting and trying its really best to open up the aortic valve, and it clicks because it bows like that. And then blood will start squirting through it. That is going to produce this characteristic type of clicking sound that we hear right in the beginning of ventricular systole. Right in the beginning of ventricular systole, after S1, you'll have a ejection click. Okay? This is what you would see in aortic stenosis and pulmonic stenosis. They have an ejection click. That's very important. After that happens, blood is going to start rushing through this area a lot in the beginning. So a ton of blood will flow through, and then less blood will leave the ventricle, less blood will leave the ventricle out through the aorta, and then the actual intensity or the volume of blood that's leaving will decrease. And so it'll actually be, again, look like this. a lot of blood will leave through the left ventricle into the aorta. So the aorta starts getting really filled. And as that time goes by, less blood is leaving through the left ventricle and into the aorta. Because we're having less blood in the left ventricle, right? As you contract and contract, less blood is going to be leaving. And so it gives this uprise from blood squeezing out through the left ventricle into the aorta. And then this downrise due to less blood leaving the left ventricle and going through the aorta. This has a very characteristic uprise and downrise. What do we call that? A crescendo decrescendo murmur. This is characteristic in aortic stenosis and pulmonic stenosis. So you have this crescendo, decrescendo, decrescendo, murmur. That is important to remember. This is what you would see in aortic stenosis and pulmonic stenosis. You would see this ejection click plus the combination of this crescendo decrescendo murmur. You would not see this in hypertrophic obstructive cardiomyopathy. You wouldn't see the click. Here's what happens in hypertrophic obstructive cardiomyopathy. Okay, so let's actually write this down here. This is particularly only for aortic stenosis and pulmonic stenosis. This one down here will be for hypertrophic obstructive cardiomyopathy. Now what happens in hypertrophic obstructive cardiomyopathy is that their interventricular septum is asymmetrically hypertrophic. So now I got this hypertrophic interventricular septum. When the left ventricle contracts and tries to squeeze blood out of the left ventricle, it's kind of just like aortic stenosis. But I'm trying to squeeze blood through this tiny little area here, just like I'm trying to squeeze blood through the tiny little narrowing stenotic valve. I'm trying to squeeze it through this left ventricular outflow tract and into the aorta. It's very narrow and it's tough for me to squeeze all that blood through. And so what happens is a ton of blood is going to rush through that area, and then less blood will leave through that area as well. And so it's going to produce, again, this crescendo, decrescendo type of murmur. Because again, I'm going to squeeze the left ventricle as hard as I can. I'm going to push as much blood through that narrow area, and that whenever the blood's leaving, a ton of blood leaves the left ventricle into the aorta and feeds it. And then over time, throughout the rest of systole, less blood will be leaving the left ventricle, so less blood will be filling the aorta. And again, it produces this classic crescendo, decrescendo type of murmur, which looks just like this, but what's it missing? This has no ejection click. That has no ejection click. So again, for this one, you'll see a crescendo, decrescendo, murmur. But again, there's no ejection click. What's another thing? If you're listening for aortic stenosis, where would I be listening? Right second intercostal space, radiation to the carotids. So this would also have an ejection click plus the crescendo decrescendo at the right, particularly, again, pulmonic stenosis is very, very rare. So we're going to just hold this off right here. It's very, very rare. So I would focus more on the aortic stenosis. But for this one, you would hear this at the right second intercostal space, and it would radiate to the carotids. In this example of crescendo decrescendo without an ejection click, for hypertrophic obstructive cardiomyopathy, this would be located, where did we say that you could hear this best? Erb's point. So you can hear this at Erb's point, which is the left third intercostal space. Does this radiate to the carotids? No, there is no radiation. And there's also other ways that we can differentiate these two via specific types of maneuvers. But that's what I really want you guys to remember here, okay? We have that also, again, aortic stenosis will be a harsh type of murmur. Hypertrophic obstructive cardiomyopathy is also a harsh type of murmur, so it's not going to be the type of quality. The pitch, they're both going to be high pitch, so they're both going to be heard with the diaphragm of the stethoscope, and they're generally both high grade, okay, high intensity. So these are things to be thinking about. So we kind of reviewed and recapped those things. If you really wanted to know the extra little part of coarctation of the aorta, how to differentiate these, this one has a systolic, crescendo decrescendo, just like both HCM and aortic stenosis. I'm going to get rid of pulmonic stenosis just because it's super, super rare. So aortic stenosis is the big one I want you to remember. For coarctation of the aorta, the best way you can differentiate this is heard at the left posterior hemithorax. That's a super obvious situation there. You ain't listening for no murmurs of aortic stenosis and hypertrophic obstructive cardiomyopathy in the left posterior thorax. You're not doing that. You'll hear that in coarctation of the aorta, okay? So that's a big thing to think about. And also there's some other things with coarctation of the aorta that just pass the scope of this lecture that I don't want to get too much into. But these are the big ones that I want you to remember. Aortic stenosis, hypertrophic obstructive cardiomyopathy based upon them being early systolic ejection murmurs. Again, ejection click with aortic stenosis, not with hypertrophic. Second intercostal space, right parasternal border for aortic, radius of the carotids. Hypertrophic, Erb's point, no radiation. Crescendo, decrescendo for both of them. That is the important thing to remember. Okay, now that we talked about that, let's come down for mid-systolic murmurs. All right, so let's talk about mid-systolic murmurs. So in these situations here, the big one that I really want you guys to understand here is called mitral valve prolapse. And sometimes that can be associated with a murmur. So in mitral valve prolapse, what's really happening in this situation is that you have very, weak type of leaflets. So there's what's called myxomatous degeneration. It kind of gets a lot of like deposition of particular types of spongy tissue in this valve, and the valve leaflet is just really weak. All right, so that's one characteristic of mitral valve prolapse, is they have very weak mitral valve leaflets. They're just super, super floppy and easy to be able to deform. Okay, that's one thing to think about. The second thing is that they have these things, they have the chordae tendineae, and they anchor them down to the papillary muscles. These are also super weak. So let's actually draw some very weak types of chordae tendineae. So we'll draw them as kind of like they're not very taut, they're not very strong, they're not really anchoring the leaflets down. They're just super loose and chill and laxed. So there could also be weak chordae tendineae, okay? And this could be due to connective tissue defects associated with like Marfan syndromes, Ehlers-Danlos syndrome, stuff like that. What happens is that whenever the ventricles go into their systole, right, they start contracting and squeezing blood, they generate enough pressure that when we want to close the mitral valve, we want the leaflets to come together, seal, and prevent blood from backflowing into the atria. That's the whole purpose. Whenever the blood hits the mitral valve, it causes the mitral valve leaflet, because it's super weak and the chordae tendineae isn't really anchoring it down. Imagine that thing just getting hit with like a rock and just blowing back. So that very weak leaflet will blow back into the actual left atrium. So now imagine this for a second, where this leaflet, which was trying to be nice and close to this one, gets bowed back here. This poor leaflet. So it gets bowed back into the left atrium. That bowing back of that valve into the left atrium causes a clicking sound. So you can kind of imagine, I guess another way of thinking about it, is imagine here I have the annulus, which holds the leaflets, okay? And here's the one leaflet here, the anterior leaflet here, and then here's the posterior leaflet. Normally it's like this, right? And it's anchored by the chordae tendineae. But in these patients who have mitral valve prolapse, that leaflet's very weak, and when the left ventricle contracts and pushes blood to snap these leaflets together, instead of it snapping together, this poor thing just starts bowing into the left atrium. And now again, what's anchoring these bad boys down, what's supposed to be anchoring them, is the chordae tendineae. Instead, because it's not anchoring them down, the leaflet's really weak, the blood will bow back, will bow that mitral valve leaflet backwards. And now there's an open space between these two leaflets where blood could easily regurgitate back into the left atrium. So not only does mitral valve prolapse have this click sound that they have, so it'll also produce a very important type of click, but there may also be an associated murmur present, where blood can regurgitate back. What kind of murmur? A mitral regurgitation murmur could also be present. So that's what it would be very interesting here. So what we see is a click that occurs right at like the point of mid-systole. So here will be my ejection click, and that's the bowing. That clicking is this part here where the mitral valve bows back into the left atrium. That's the click. But then also, if we have the regurgitation of blood flow due to not having a poor seal, you may also have a regurgitation murmur that can also occur after the ejection click. And that's an important thing to remember. And you think about, where would you have this mitral valve prolapse with the murmur? Like, where would it be best audible? Review it. That's that left fifth intercostal space. Mid-clavicular line. Does it radiate? Well, if there's the mitral regurgitation murmur, it will, and it could potentially radiate to the axilla. This would be high pitch. This would be a blowing type of quality. You guys are getting the point, and it's pathological, so it'd likely potentially be like a grade 3 or above. So this is the whole concept that we're continuously, repeatedly going through so that we anchor these types of things down in our brain. All right, so that's the mitral valve prolapse. So in a mid-systolic ejection click, and if there's a murmur that presents because of the poor sealing, you can get a regurgitation murmur like a mitral regurgitation murmur. That's an important thing. All right. The other thing is we'll talk about maneuvers a lot later, things that can cause the click to come earlier, murmur to be longer, click to come later, murmur to be shorter. We'll talk about all those things a little bit later. All right, the next situation that I want you guys to remember is we can also have mid-systolic murmurs without the click, and these are actually called physiological murmurs. So they're physiological, functional. And when I talk about these murmurs, there are particularly two reasons. One is you have a hyperdynamic circulation. So a hyperdynamic circulation or state is whenever your left ventricle is just a clanging and a banging. It's pumping out blood through the left ventricle out into the aorta. And when it's flooding that blood through the aorta, imagine whenever that blood is flooding through the aorta at a high velocity, that high velocity is going to produce turbulence of blood flow, right? You're going to get turbulence of blood flow. And if you get increased turbulence of blood flow, that's going to precipitate murmurs. It's also going to cause these like aortic valve, which is flowing through, to kind of vibrate a lot because you're hitting that valve with so much intensity and so much velocity that when it gets hit, it'll actually vibrate a little bit. So there'll be a turbulence of blood flow from the high velocity, and the high velocity will actually vibrate the valve. And that'll produce a murmur that will be audible. Now, this is usually due to hyperdynamic states. So what are some hyperdynamic states? We already talked about that, right? So it could be fever, it could be sepsis, it could be exercise, it could be thyrotoxicosis, because all of these things are increasing your sympathetic nervous system, right? They're all increasing your sympathetic nervous system. It could be high volume states like pregnancy. We talked about that one. It could be high outflow states where your cardiac outputs are having to be higher, such as in beriberi. It could be in situations like an AV fistula, or even in severe anemia, right? We talked about all of these over there with the physiology of murmurs, but it's the same concept. When these murmurs occur, it actually starts at mid-systole and then continues throughout the rest of late systole all the way until we get to the next heart sound. So this starts at, so we have S1, and then right after S1, which is the closure of the mitral and tricuspid valve, a little bit later we'll get our mid-systolic murmur, and it'll terminate right at S2. And again, we'll have S1. Same thing with the mitral valve prolapse. We'll have S1. Right after S1, you get an ejection click with a murmur that could be present if there's a mitral regurgitation. Then you get your S2 and then your S1. So that's what's happening in this situation. Now there's one more thing that you guys have to remember besides hyperdynamic states. And this is important for your test, which is called the Stills murmur. This is more important to kind of like your pediatric patients. We'll put pediatrics. This is usually in young children. Okay, it's a benign finding, so it's benign. Again, it's kind of supporting the fact that it can be physiological or functional. It's not a pathological finding. And usually this is a grade that's less than 3, so usually like 1 to 2. What happens in here is the etiology behind this we don't really know, but it's the same concept. There's a hyperdynamic state in these young children where there's a lot of blood that's actually being flowing across the aorta, right? A lot of blood flowing across the aorta. And again, there's a high velocity of blood flowing through the aorta. That's going to cause turbulence. Turbulence will precipitate a murmur, and it's also going to cause vibration of that aortic valve. In these situations, one of the big things for both of these is you can modulate these murmurs. We're not going to talk about it later, so we'll talk about it now, is you can modulate these murmurs in a particular way where you can increase the intensity of a Stills murmur in one particular way and decrease the intensity of a Stills murmur in another way. And it really comes down to venous return. If you want to increase the intensity, you want to increase the venous return. If you want to decrease the intensity, you want to decrease the venous return. So it's a simple concept. We increase venous return by having someone squat down or having them lay down flat and lift their legs. we have them reduce their venous return by standing up quickly or by having them valsalva, like they're bearing down to take a poop, and those situations that can reduce your venous return. The whole concept of if you increase venous return, you increase the volume of blood that's being entering into the heart. If you have more blood in your heart and your heart's already pounding, it's going to pound more blood through the aorta. That's more velocity, that's more turbulence and intensifying the murmur. If there's less blood volume, this heart's still contracting hard, but you're not pushing as much volume. That's less force, less velocity, and less turbulence of blood flow, decreasing the intensity of the murmur. So that's one of the big things to be thinking about for these types of murmurs. All right, we talked about mid-systolic murmurs really well. Now let's go ahead and talk about holosystolic murmurs. All right, so let's talk about holosystolic murmurs. So holosystolic murmurs are different in comparison to early and mid. How? It's holosystolic is occurring throughout the entire systolic period. So from S1 until S2, there's going to be a murmur present. And so that's one of the big things. Now there's two particular kinds of things that can happen here. One is there's a regurgitation murmur or there's a VSD. That's what we got to be thinking about. Holosystolic, okay, mitral regurg, tricuspid regurg, or VSD. Think about that in your head. That's the differential. So the first things first, let's talk about mitral regurgitation and tricuspid regurgitation. So mitral regurgitation or tricuspid regurgitation. In these situations, again, what's happening? The ventricles are going to be in systole. They're going to be contracting. When they're contracting and they're starting the contractile period, right when the left ventricle contracts to try to push blood up into the aorta, it's going to squeeze blood back through these incompetent valves into the atria. Blood flow across an incompetent valve will precipitate a turbulence of blood flow because it's going to bang off the atrial chambers and cause a murmur. That murmur is going to occur without any kind of clicking sound, without any kind of snapping sound or anything like that. It is going to be occurring throughout the entire systolic time period. And we know that that's the systolic time period because, again, closure of the mitral and tricuspid valve are supposed to occur at S1. And then again, you have S2, which is when the aortic and the pulmonic valve close, which starts the onset of diastole. And then again, we go back to S1. So it has to occur between S1 and S2. But again, it is holosystolic occurring throughout the entire time period. And again, the same thing that would happen here with mitral regurg would be the same thing with tricuspid regurg. You'd have the right ventricle, it's trying to pump blood out into the pulmonary artery, but because we have this incompetent valve, we're rushing blood across the incompetent tricuspid valve back into the atria, the right atrium, causing blood to hit the right atrium and cause turbulence of flow and precipitate a murmur. That's the big thing. And again, we can establish here with these that mitral regurgitation would be best heard at the left, what? Fifth intercostal space, mid-clavicular line, and then it would radiate where? It would radiate to the axilla. This would be a very high-pitched, it would be blowing in quality, right? You get the point, and it's going to be a high grade. If it's tricuspid regurgitation, that's relatively uncommon, but let's still mention it. That would be where? That would be the left fourth intercostal space, peristernal border, and generally we don't have any literature that supports a particular radiation of this one. But again, it might be a little bit more of a higher pitch, even though that side is a little bit of a lower pressure system. It could be a variable pitch, I would say. The grading is usually a little bit more intensified, though it's a higher grade. And again, the quality of it will be more of a blowing type of murmur because it's a regurgitation murmur. All right, and we'll talk about different types of maneuvers that we can utilize to particularly focus more on this one because it's more common, ways that we can intensify or decrease the intensity of mitral regurgitation murmurs. Okay, boom, shakalaka, we did that one. All right, next one that we have to talk about, VSD. Now with VSDs, these are very interesting. So with ventricular septal defects, right, well, the problem with this one is that when the left ventricle contracts, you want it to pump blood out into the aorta, right? That's the goal, and it will. It'll still do that even with the VSD because you're going from high pressure to low pressure in the ventricle to low pressure in the aorta. But guess what? The left ventricle also is higher pressure than the right ventricle. So when it's pumping blood out into the aorta, it's also pumping blood across the ventricular septal defect into the right ventricle. And whenever you do that, that's going to push blood here and cause this turbulence of blood flow for two reasons. One is you're having to squeeze blood through a small little tiny opening within that septal defect. That's a higher velocity, and that's going to cause a increased turbulence. It's also a high pressure gradient, so it's going to produce a higher pitch. But also, if I push blood across this area, it may bang up against the right ventricular walls and cause more turbulence, and again, precipitate murmurs. You get the point. This right here is still going to produce a murmur that occurs throughout the entire systolic time period. It's throughout the entire systolic time period. And again, it's between S1, so S1 is the closure of the tricuspid of the mitral valve. That's still going to close. And S2, assuming that they have normal mitral valves and normal tricuspid valves, this should close. S2 is the closure of the aortic and the pulmonary similar valve. And then again, we get back to S1. From S1 to S2 is systole. So it has to occur during systole and occurs throughout that entire time period. Big thing to think about with the VSD is the actual intensity of the murmur is dependent upon what thing? Just to remind you, intensity increases with decreasing diameter VSDs. So a decreasing diameter VSD will cause higher velocity of blood flow. So remember that. The smaller the VSD, the more intense, loud the VSD will be. And so more audible it will be. The larger the VSD, the larger the diameter, the less the velocity, the less the turbulence of blood flow, and less intense or loud the VSD will be. That's an important thing to remember. VSDs though, when you're listening for these, where are we particularly listening for them? They would listen more particularly at what area? The same area as the tricuspid valve. So you would particularly listen around the left, fourth, intercostal space, okay? Parasternal border. So parasternal border. These are big things to be thinking about, my friends, okay? And again, with ventricular septal defect, this would be more of a, what type of heart sound? If you're comparing this from mitral regurg, because this is the more common one. Mitral regurg versus the VSD, this would be more harsh in nature. Whereas in patients with mitral regurg, we would consider this to be more blowing, okay? Or musical. This one has a radiation where? Into the axilla. This one generally there isn't a particular literature at the base that says where exactly it may radiate. If it does radiate, maybe it's going to be a little bit more on the right lower sternal border, but again, there's no literature to actually support that. Okay, that's the big things to think about with your holosystolic murmurs. Okay, let's now move on to diastolic murmurs. So diastolic murmurs, let's actually talk about this on the graph here. Again, S1 begins the onset of ventricular systole, closure of the mitral valve and tricuspid valve. S2 is the closure of the aortic valve and the pulmonary similar valve. And that indicates from here to the next S1, this is ventricular diastole. That's the period when the ventricles are relaxing and filling with blood, right? Okay. There's two particular differentials that you want to think about with diastolic murmurs. Aortic regurg, which is the more common one, but you also want to think about the associated one, pulmonic regurg. We're going to pretty much mention it, but think more particularly aortic regurg. And then mitral stenosis or tricuspid stenosis, but again, think more about mitral stenosis since it's more common. Okay, so those are the two differentials that we're going to write down here. So let's write down here. First one is going to be someone who has aortic regurgitation, pulmonic regurgitation. But again, focus more on the aortic regurgitation because it's way more common. In aortic regurgitation, what is happening? This aortic valve is dookie. It's not very good at doing its job. So when blood is supposed to go from the left ventricle out into the aorta, it's supposed to go out into the aorta and flow out into the systemic circulation, right? But whenever the aorta takes that blood in, it accommodates it, it recoils, it smashes the blood back down towards the left ventricle. There's an incompetent and leaky valve, so blood is just going to flood backwards and across that incompetent valve into the left ventricle. It's going to bang up against the left ventricular wall and produce turbulence of blood flow, which is going to precipitate a murmur. Man, if that happens, when would this happen? This would happen right at the onset of ventricular diastole, right at the onset, at S2, right after S2, boom, you can get the aortic regurgitation or pulmonic regurgitation murmur. So when the blood flows back across that incompetent valve, you will see this murmur, and here's where it's really interesting. It'll start off right here after S2. You're going to see that as the blood is flowing across, more blood will flow across in the initial time period. All right, so you'll have a high volume and early diastole, and then a low volume flowing across in the later phases of diastole. Okay, so a lot of volume is going to flow across that actual aortic valve into the left ventricle in the beginning phases, and then less volume will flow over in the later phases. So it'll kind of look something like this. So it's a diastolic murmur, but it's decreasing in intensity throughout diastole. What do we call this? A diastolic decrescendo murmur. So what is this called? This is called a diastolic decrescendo murmur. Now, that is one important thing to remember. The other thing to remember here is not only is it diastolic decrescendo, is think about, since aortic regurgitation is the one that I want you to remember, where would we be listening for this one? Again, we would be listening at the right second intercostal space parasternal border. Where does it radiate? It radiates to the, where? Left upper sternal border or left second intercostal space generally. Okay? The other thing is, what's the quality of it? Would you describe this as blowing? Yes, it's blowing or musical. Okay? And then again, pitch, it'd be very high pitch. And on top of that, what else? It would also be a very high grade. So you guys get the point here with this. And we get to say the same thing about pulmonic regurgitation. It's just not very common. So we commonly just think about aortic regurgitation. So again, a diastolic decrescendo murmur, because again, think about as blood is flowing from the aorta into the ventricle, there's going to be more blood that's flowing in initially, and then eventually there's just less blood in the aorta to come across into the left ventricle. And so the less volume actually enters. And so as less volume is moving in, there's less turbulence of blood flow, less velocity of blood flow, and again, less turbulence, less intensity of the murmur as we go towards the time period of beginning ventricular systole. Okay, next one, we said aortic regurgitation was the big one to think about for diastolic murmurs. You can also think about pulmonic, but the other thing we said was, what if it's not those? What if it's actually something like mitral stenosis or tricuspid stenosis, with the emphasis being more on mitral stenosis because it's way more common. Tricuspid stenosis is not too common. In these situations, what happens is something very interesting. You want blood during diastole. So again, this was all happening during diastole when the ventricles are supposed to be filling with blood only from the atria. But instead, these suckers are getting filled by the pulmonary artery and the aorta undesirably because of the incompetent leaky aortic valve and pulmonic valve. In this situation, the valves here are fine, valves here are fine. There's no problems with those valves. And blood should not be coming this way. Okay, this is not happening. No blood is backflowing from the pulmonary artery or the aorta. In this situation, we only want blood to go from here to here, right? That's what we want normally during diastole. So when the ventricles are supposed to be relaxing and accommodating that blood flow, we only want them to be coming from the atria. What if the blood flow isn't coming from the atria because there's a very stenotic and fibrotic and calcified mitral or tricuspid valve? Oh man. So in this situation here, here's what happens. Take the mitral valve, for example. Here's your mitral valve. When you have your mitral valve like this, let's kind of draw it like this. We'll have it here and we'll have it here as the mitral valves. Okay. So here's your mitral valves. They're very, very fibrotic and stenotic, right? So we'll draw like some fibrous tissue or, calcifications of these valves. They're very, very stiff. They're very calcified. What we want to do is we want to push blood and snap these valves open, right? So generally what we would like to see in a perfect world is we want to see a situation like this, where they would fly open and blood would easily flow down from the atria into the ventricles. But these valves are super fibrotic, super stenotic, super calcified, and they're very difficult to open. What happens is your atria contract as hard as they can and generate a lot of pressure to push blood through that valve and pop it open. And so what happens is, in these situations here, is when you kind of like just crack these like old fibrotic valves open, it kind of makes this snapping sound. And we call that sound that it makes whenever you like quickly snap open the mitral valve or the tricuspid valve, the opening snap. And that's going to occur right at the beginning of diastole. So again, if you think about here, you have S1, you have S2, which is again the onset of ventricular diastole because that's the closure of the aortic valve and the pulmonic valve. Those are closed, no backflow. And we should have blood coming from the atria into the ventricles. Well, what happens is the blood is not wanting to come as easily, and so then the atria have to contract, they have to kind of generate a lot of pressure and snap open that mitral valve or tricuspid valve. When it snaps it open just enough to crack that opening enough to get blood into the ventricles, that is called the opening snap. Then think about it like once you open it, you have a lot of blood waiting in the atria to get down into the ventricles. Once you open it, and it took a lot of time to pressure and stress to open that valve up, once you open it, a ton of blood is going to flow down into the ventricles very quickly, empty the atria, and it's the same concept. There'll be a lot of volume that'll cross the actual mitral valve or tricuspid valve early, and then less volume because they're starting to get empty as it crosses the mitral valve later in diastole. So then you get something like this. Let's actually increase the intensity of our opening snap. Let's bring it up a little bit here. Opening snap's right there. Now, as a lot of volume of blood is entering, it's going to start off at the highest peak, high volume, high velocity, right? And it's going to be a lot of velocity, and then there's going to be a lower velocity of blood. Okay, as less blood is actually present, there's going to be less blood that's flowing across that area. So now there's going to be a high intensity moving towards a low intensity. Holy crap, that looks just like aortic regurgitation and pulmonic regurgitation, doesn't it? The only real kind of difference here is that, well, there's a couple differences here. So there's still a diastolic decrescendo type of murmur. And let's actually kind of separate these a little bit so we can see the opening snap. So there's our opening snap right there. And then again, right after that, we have the, what is this? Our diastolic decrescendo murmur. But one of the big differences is that you have an opening snap and the diastolic decrescendo murmur. You do not have an opening snap and diastolic decrescendo murmur present in aortic regurgitation and pulmonic regurgitation. So that's one thing. Second thing is if we take into consideration here that mitral stenosis is the more common type of event here. Mitral stenosis, when we think about this one, it's going to be where? Where would you hear it? Left, fifth, intercostal space, mid-clavicular line. Does it radiate? There's actually none that we didn't talk about radiation. There was no radiation particularly for mitral stenosis. Okay, good. The second thing is, not only is it that, but also how do we classify the stenosis? Well, stenosis, it was going from atria to ventricles. That's a low pressure gradient, but there's a large volume of blood to try and push across the valve early. So that would actually cause more of kind of a, unfortunately it's not generally enough to get the pitch up high enough, but it is a low pitch. But on top of that, we kind of define any kind of like mitral stenosis or tricuspid stenosis or aortic stenosis. We define those more as like a kind of like a harsh or rumbling type of sound. You know, we actually give, particularly for mitral stenosis and tricuspid stenosis, we use the term a rumbling quality. So we prefer to use harsh for the aortic stenosis and pulmonic stenosis, and we prefer to use the rumbling terminology for the mitral stenosis and the tricuspid stenosis. So we call this a diastolic decrescendo rumbling murmur for mitral and tricuspid, whereas this is a diastolic decrescendo blowing murmur for aortic and pulmonic regurgitation. Okay, we've covered the diastolic murmurs. Let's move into the next one, which is the continuous murmurs. All right, so let's talk about continuous murmurs. Continuous murmurs are interesting in the sense that they occur throughout the entire systole and diastole, right? So again, if we were to take care of our cardiac cycle here, looking at the heart sounds, we have S1, closure of mitral tricuspid valve, onset of ventricular systole. S2, closure of aortic and pulmonic valve, onset of ventricular diastole, back into S1. If it's a continuous murmur, it's going to have to occur throughout systole and throughout diastole. Right? So between S1 to S2 and between S2 to S1. Now, what would be the particular reasons for that? Whenever you hear continuous murmurs, you automatically want to assume patent ductus arteriosus, PDA. So we'll call this patent. I'll be a good boy. I'll actually write this up. Patent ductus arteriosus. But again, we prefer to call this, I like to say PDA. Not public displays of affection, but patent ductus arteriosus. Now, what happens in patent ductus arteriosus is that normally, this has happened in normal like fetal life, there is a little connection here. So imagine here you have the pulmonary artery, and the aorta, there is this little like connection here between the aorta and the pulmonary artery. And the whole purpose of it is whenever the baby is in the amniotic fluid, it's not breathing. And so we want not very much blood going from the right ventricle to go to the lungs, so we divert it through that little ductus arteriosus into the aorta so that we bypass the lungs. Well, when you're born, your left-sided pressures, and throughout adulthood, your left-sided pressures are actually much higher. So your aortic pressure is much higher than your pulmonary artery pressure after birth. So that's a big thing. That's one big thing to note, is that aortic blood pressure, not aortic, aortic blood pressure, aorta pressure is much greater than the pulmonary pressure. And that honestly does not matter at what point in time in the cardiac cycle. It's always higher, regardless if it's systolic and diastolic. That pressure is higher in the aorta than the pulmonary pressure. So think about that for a second. Your left ventricle pumps blood out into the aorta. When it goes into the aorta, it obviously can go, through all the vessels, all the branches of the aorta, off the branches off the aortic arch, down through the descending aorta, so on and so forth. But then there's this other tube where there's a high pressure in the aorta, so high pressure in the aorta, right in here. And then the pulmonary pressure is low. So then the pulmonary pressure is low. Blood can easily just flow from this area into this area. And that can happen during systole, and it can happen during diastole, where blood is just, no matter what, if blood is in the aorta, whether it's systole or diastole, it can continue to flow from the aorta into the pulmonary artery throughout systole and diastole, because as long as the pressure in the aorta is greater than the pressure in the pulmonary artery, it doesn't matter. As long as there's blood there, it's going to flow in that direction. And so what happens is this causes a constant shunt. It causes a constant shunting of blood, if you will, from aorta to the pulmonary artery via the patent ductus arteriosus. And that produces a continuous type of murmur. So you would hear that during systole, and you would hear that during diastole. Now, technically in this, you would have this continuous murmur as a very interesting type of situation, right? And actually, what's interesting is usually the intensity kind of increases throughout systole, because you're going to have more of that blood shunting into the aorta, and then eventually throughout diastole, less of that blood is shunting from the aorta into the pulmonary trunk. So it kind of has like this, in a way, crescendo during ventricular systole and kind of a decrescendo during diastole. But either way, it's kind of having this continuous type of process that is occurring. All right, so because there's this constant shunt of blood from the aorta into the pulmonary artery during systole and diastole, you get kind of this nice little interesting type of murmur here that you see continuous, in the sense that it's continuing to occur during systole and continuing to occur during diastole. Slight crescendo fashion between the ventricular systole, and then again, slight decrescendo fashion during the diastole. What's really interesting is where you would hear this murmur. And this is kind of the one where it's just like super random. And that's why it's kind of easier to remember in that sense. For patent ductus arteriosus, you want to listen on the left, kind of like infraclavicular region is what we say. So we say left infraclavicular area. So left infraclavicular region. That's particular for the PDA. So you want to listen to that left infraclavicular area. Okay, so again, here's your clavicle. Just underneath the clavicle, particularly, is where you're trying to listen for that patent ductus arteriosus. It's a continuous murmur. And here's another term that you can't forget. Not only is it continuous, but we use the term, it's machine-like. It is a machinery or machine-sounding type of murmur that is continuous throughout systole, diastole, left infraclavicular region, and it is machine-sounding. Okay, here's the next thing. Sometimes you can hear this murmur, but you're listening on the right infraclavicular region. You're like, is this a PDA? Sometimes it's actually a very benign finding, and you want to have a differential for that. In that situation where you find what's called a right, when you have right infraclavicular, a right infraclavicular murmur that is continuous, you want to think about something called a cervical venous hum. It is way more common that it's going to occur on the right infraclavicular region, less common that it does occur on the left infraclavicular region. Let's say though, just to kind of mess around here, let's say that you have this kind of murmur that's present, this cervical venous hum, and it's on the left infraclavicular region. And you're like, oh dang, is this a PDA because it's continuous? It sounds somewhat machine-like. It's usually not very loud, as intense and machine-like as a PDA. But let's say that it's difficult to differentiate. It's a continuous murmur. You hear it at the left infraclavicular region. What can I do to make me definitely feel more comfortable that it's likely a cervical venous hum in comparison to a PDA? You can do a particular maneuver. What you can do is you can have them flex their neck. When you flex their neck, in a patient with a cervical venous hum, the issue is the blood flow in the internal jugular veins in this one. There's this kind of like continuous blood flow through the internal jugular veins, and the turbulence within the internal jugular vein is producing the murmur. If you have them flex their neck, you compress the internal jugular veins. Or if you have them rotate their neck to the side, you compress the internal jugular vein, reducing the blood flow in the internal jugular veins. And that would decrease the intensity of the murmur in a cervical venous hum, and it would not decrease the intensity of the murmur in a PDA. Man, so this will decrease intensity in the venous hum, but it will not increase the intensity, not decrease the intensity in the PDA. So again, continuous murmur, please don't forget PDA due to a constant shunting of blood from the aorta into the pulmonary artery during systole and diastole because its pressure is higher. It's heard in the left infraclavicular region. It's also machine sounding. Generally, in this situation, you may think, ooh, I hear a continuous murmur around the right infraclavicular region. I think, could it be a PDA? Or let's say that you hear it on the left infraclavicular region by some potential chance, and you think, is this a cervical venous hum or is this a PDA? I don't know. One's due to jugular venous flow, one is actually due to a patent ductus arteriosus. If I have them flex their neck, it'll compress their jugular vein and reduce the intensity of the murmur. If it reduces the intensity of the murmur, it's a cervical venous hum. If it does not, it is a PDA. Boom shakalaka. Let's finish this up with ways that we can change the intensity of a murmur in senses that we can utilize maneuvers or positions to increase the intensity of the murmur, decrease the intensity of the murmur, cause a click to come early, cause a click to come later, cause a murmur to be shorter, cause a murmur to be louder. We're gonna hit all that, let's do it. All right, so we've really went pretty hard so far, guys. Hang in there with me, we're almost there. We talked a lot about particularly the physiology behind murmurs. We talked about the location, the pitch, the quality, the radiation, the intensity of murmurs. We went over if they're in systolic type of murmurs, diastolic, continuous. What's the configuration of the murmur? We really hit home on that. But I think one of the most important parts is that can we do a particular maneuver or position that changes the intensity of the murmur to help me clinch the diagnosis? Let's talk about that. So the first one is inspiration. I think I kind of helped to get this in a way where it's easy to remember. Inspiration is one category. So inspiration, when you take a deep breath in, you drop your intrathoracic pressure. And when you drop your intrathoracic pressure, it creates a kind of like vacuum effect that sucks blood into the right side of the heart. So you increase right heart filling. So again, what happens with inspiration? You drop your intrathoracic pressure. Because when you drop your intrathoracic pressure by taking a deep breath in, that's going to increase the venous return. If you increase venous return, you increase the right-sided filling. So all the murmurs on the right side that are dependent upon that volume, as you have more blood on the right side of the heart, if you're pushing more blood back into the atria and tricuspid regurgitation, that's going to increase it. If you're pushing more blood across the tricuspid valve, if you're pushing more blood across the pulmonary valve, that's going to increase all the types of right-sided murmurs. So increasing right filling increases the intensity of right-sided murmurs. So that would infect which ones? That would alter the tricuspid stenosis, tricuspid regurgitation, pulmonic stenosis, and pulmonic regurgitation. Boom, roasted. Let's move on to the next one. Expiration. In expiration, you actually are exhaling. It's going to do what to your intrathoracic pressure? Increase the intrathoracic pressure. When you increase the intrathoracic pressure, what you do is you actually squeeze on the pulmonary vessels. So you increase your intrathoracic pressure and it squeezes on the pulmonary vessels. And that increases the venous return, particularly to the left side of the heart. So that increases left-sided filling. If you increase left-side filling, now you have more blood within the left ventricle. If there's more blood within the left ventricle, you can now increase the blood flow across all these valves, or increase the regurgitation of volume of blood across these valves. That increases the intensity of all left-sided murmurs. So that increases the intensity of all left-sided murmurs. So that's one way that you can help to differentiate between like pulmonic stenosis and aortic stenosis. Aortic regurgitation and pulmonic regurgitation. Mitral stenosis, tricuspid stenosis. You guys get the point. So this would affect more the, again, mitral stenosis and mitral regurgitation, and aortic stenosis, aortic regurgitation. Boom, we good. All right, next one. Leaning forward. What the heck does this have to do with anything? When you have a patient lean forward, what you do is you bring their aorta and the aortic valve closer to the chest wall. So any type of murmur or any kind of like abnormality that is close to the aorta or close to the aortic valve is going to increase the intensity of that murmur. So if you lean forward, you bring the aorta and aortic valve close to the chest wall. And that will increase the intensity of those murmurs that are close to the aorta and the aortic valve. What types of murmurs are close to the aorta and the aortic valve? Oh my gosh, we're so good at this. Aortic stenosis, aortic regurgitation, hypertrophic obstructive cardiomyopathy, believe it or not, too. And one more, coarctation of the aorta. We never really talked about that, but again, it was a type of systolic ejection murmur, right? Early systolic murmur. And again, it didn't have a click, but it usually heard the left posterior hemithorax. And again, this one would also could be heard easily if you had them lean forward. I would put more of an emphasis of leaning forward on aortic stenosis and aortic regurgitation though. Okay, what else? Keep moving on, keep moving on. All right, so the next thing I want you guys to think about is something called the left lateral decubitus position. So the left lateral decubitus position is when you have a patient lay on their side. So you're having that, you can either have them lay supine and then you put them on their side. So they're laying on their left side. And what you're doing is you're bringing the mitral valve and even part of the apex closer to the chest wall, which will increase the audible ability to hear, or increase the intensity of abnormalities near the mitral valve. So it brings mitral valve closer to the chest wall. And if you do that, you're going to increase the intensity of the murmurs in that vicinity. Increase the intensity of murmurs near the mitral valve. So this would include mitral stenosis, mitral regurgitation, and mitral valve prolapse. Man, we good. All right, so inspiration, increase the intensity of right-sided murmurs. Expiration, increase the intensity of left-sided murmurs. Leaning forward, bringing the aortic valve closer, aorta closer. Increase the intensity of aortic stenosis and aortic regurg. Laying on their left side, increasing the intensity of mitral stenosis, mitral regurg, mitral valve prolapse. Okay, the next one, which is really high yield, is squatting and passive leg raise. What does this do? When you squat down, you squeeze on, you actually contract your muscles and squeeze on some of the veins in the lower extremity and push blood up to the heart. Okay? So when you squat, or if you're having a patient lay flat and you lift their legs, you're having blood drain from their legs into their abdomen up to their heart. And again, that helps to increase venous return. But either way, these two mechanisms, what they do is they increase venous return. If you increase venous return, you increase what's called the preload to the heart, right? You increase preload of the heart. When you increase the preload of the heart, you're going to increase what else? This generally increases the intensity of all murmurs, because you're going to have more stroke volume. So what happens is if you have a higher preload, you have a higher stroke volume, and so you're going to have more blood that can flow across valves, or like in the stenotic in a forward way, so more blood flowing across a stenotic lesion, or more blood that can flow backwards across a valve in a situation of an incompetent valve during regurgitation. So what I want you to remember is increased venous return increases preload, increases stroke volume, which will cause more blood to flow forward or more blood to flow backwards So in a stenotic valve, more blood will flow across that. In a regurgitant valve or incompetent valve, more blood will flow across that. It increased the intensity of all murmurs with 2 exceptions. So I want you to remember these 2 exceptions. So the exceptions to this is what's called hypertrophic obstructive cardiomyopathy and mitral valve prolapse. That's what I want you to remember. Increasing venous return increases preload, increases stroke volume, increases forward flow across the stenotic valve and backward flow across a regurgitant valve. That increase the intensity of all murmurs with 2 exceptions, HCM or hypertrophic obstructive cardiomyopathy and mitral valve prolapse. Let's explain why that is an exception. Because it's easy to remember this, right? It's easy to remember this part, but then we have to make sense as to why squatting increased the intensity of all murmurs except these. Okay, in hypertrophic obstructive cardiomyopathy, here's what I want you to think about. You have, in this situation here is your hypertrophic obstructive cardiomyopathy. You have a increased venous return, all right? That means that there's gonna be more volume in the left ventricle. What is that called? When there's more volume in the left ventricle, especially during diastole. There's what's called an increase in left ventricular end diastolic volume, okay? In hypertrophic obstructive cardiomyopathy, their problem is they have a asymmetric hypertrophy of their septum. So their septum's like this. It's bowing inwards and blocking this left ventricular outflow tract. It's difficult to get blood through that area, and that's causing a murmur. Which type of murmur? Systolic ejection murmur, really? Which one? Early systolic murmur. Now, if I have all of this volume that I'm increasing venous return by squatting or passive leg raises, I have more volume, and what that's going to do is that volume is going to try to stretch and push down and mash down on that dynamic obstruction. So what I'm trying to do by this is decrease the intensity or decrease the obstruction of that left ventricular outflow tract. So imagine now if I have more blood, I can stretch this actual outflow tract out more. And so it decreases what's called the left ventricular outflow tract obstruction. I know that's a lot, but it's decreasing that dynamic obstruction. If you decrease the dynamic obstruction, that means more increased blood flow across that area. And if there's an increased blood flow across that area, do you think it's going to make as intense of a type of crescendo decrescendo murmur now? No, because I relieved their dynamic obstruction, which was causing their crescendo decrescendo murmur. If I have more volume, I'm stretching out the dynamic obstruction, relieving the obstruction, opening up that area for more blood to flow through easily in comparison to it normally. And so this will do what to the intensity of the murmur? This will decrease the hypertrophic obstructive cardiomyopathy murmur. So normally, increased venous return from squatting or passive leg raise increase the intensity of all murmurs except for hypertrophic obstructive cardiomyopathy because it stretches out the obstruction, opening up that left ventricular outflow tract. More blood can flow across that area and it decreases the hypertrophic obstructive cardiomyopathy murmur. Oh, wow. Okay, what about mitral valve prolapse? So this is the next one. Mitral valve prolapse. We got to talk about 2 scenarios. Normally, what happens, and then when there is increased venous return. Okay, normal mitral valve prolapse, what happens is you get something to click, right? You'll get the click, something like this. Let's actually do a different color here. Let's do the click, which happens around mid-systole, right? So you get the click, and that click sound is due to the bowing or prolapsing of the leaflet into the atrium. Then after that, you get the what type of murmur? You get the regurgitation murmur that can also present there, okay? Now, here's where it gets cool. In a patient who has mitral valve prolapse, you increase their venous return. Here's the way I like to remember it. I don't know why, it just helps me remember. If you increase venous return, think about the ventricle being more filled. So think about this being the space of the ventricle. So here's my ventricle, okay? That's my ventricle, the little space there. So here, I'll kind of striate it a little bit for you. Here's my ventricle. That's normal filling. Now what I'm going to do is I'm going to fill it up more because I'm increasing the venous return. Oh, baby, if I increase this bad boy and I have it have more venous return, what happens now? There's only a small amount of distance for the click and the murmur. Uh-oh. The click will come a lot later and the murmur will be much shorter. Now, obviously, this isn't why it happens, but it's easy to remember it this way. More volume In this situation, your left ventricle is going to have a lot more volume. It's going to take a longer time for it to contract and push all of that blood against the mitral valve to shut it. So it just happens a little bit later, where the click comes later, because now the left ventricle is filled with all this blood. It has to contract and squeeze all that blood. It takes a little bit more time to squeeze all of that blood out of the heart or close the mitral valve. But an easy way to remember that is more volume. There's less room for that click now, less room for the murmur, so the click comes later. So we say the click is later and the murmur is shorter. Okay? So what can we say whenever we have someone squat or do a passive leg raise? It increases venous return, which increases preload, increasing stroke volume, blood flow across the stenotic valve, blood flow across a regurgitant valve, increasing the intensity of all of those murmurs. Two exceptions. Hypertrophic, it relieves the obstruction to have more venous return, decreasing the intensity of the murmur. Mitral valve prolapse, it causes more volume, takes a longer time for the left ventricle to depolarize, a longer time before it actually causes the mitral valve to prolapse and the associated murmur. And so the click comes later and the murmur is shorter. Easy way to remember it, think about the ventricle as the space between when the click comes. If there's a larger ventricle, meaning it's more filled, the click will come later and the murmur will have to be shorter, which is going to make this stuff a lot easier now. All right, so let's talk about the next thing, which is the Valsalva's maneuver or standing. Valsalva's maneuver is an interesting way. It's a way of decreasing venous return. It's whenever you try to poop, you're trying to get chocolate rain to flood from your Hershey Highway. When that situation happens, you're bearing down. You're like, you gotta drop this B-boy. And when you do that, you close off your glottis and increase your intrathoracic pressure. All right, that's what you're doing. You're increasing your intrathoracic pressure. When you increase your intrathoracic pressure from the Valsalva's maneuver, that is actually going to create less of a vacuum effect to pull blood up into the heart and to the right side of the heart. So you're going to reduce the venous return to the heart. Because you're increasing intrathoracic pressure, it's going to be harder to bring blood from your inferior vena cava or superior vena cava into the heart because there's such a high pressure inside of the chest. Things like to go from areas of high pressure to low pressure. If your chest pressure is really high, you're not going to yank blood into the heart from the inferior and superior vena cava. And so because of that, you get a decrease in venous return. If there is a decrease in venous return, what does that do? Decreasing venous return will actually cause there to be less preload. If there's less preload, that will decrease stroke volume. That means less blood is flow across a stenotic lesion and less blood is going to flow across an incompetent valve and a regurgitant lesion. That means that there's going to be a decreased intensity of all murmurs, both the right and left-sided, with two exceptions. And what is those exceptions? The exceptions for this situation here would be hypertrophic obstructive cardiomyopathy. Let's actually keep it the same kind of consistent here. We put hypertrophic obstructive cardiomyopathy and mitral valve prolapse. Okay? So again, big thing to think about is whenever you have someone squatting or passive leg raise, you increase the intensity of all their murmurs because you increase their venous return. In Valsalva and standing, you increase their intrathoracic pressure, dropping their venous return, decreasing the intensity of all murmurs except for these. Why? Okay, this should actually be relatively easy now because we're just repeating what we did. In this situation for hypertrophic obstructive cardiomyopathy, you have a reduction in venous return. Okay, because of this process. When you have a reduction in venous return, you get less blood that's filling into the ventricles, especially at the end of diastole. So there's a reduction in the left ventricular in diastolic volume. In patients who have less of the volume in the heart, are they going to relieve the left ventricular outflow tract obstruction? Well, there's less volume. No, you're not going to have as much of the blood to stretch out the heart, so you're not going to stretch out the left ventricular outflow tract obstruction. So imagine if there's a lot of volume, you'll stretch it out. If there's very little volume, now the obstruction's worse. So now I increase the left ventricular outflow tract obstruction. Now imagine having to squeeze blood through this little area. Oh my gosh, very little blood is going to flow through that area. So there's going to be decreased blood flow across that area. And that is going to do what to the intensity of the hypertrophic obstructive cardiomyopathy? It's going to intense it like a mofo. So you're going to have a high intensity murmur. So it's going to increase the intensity of the hypertrophic obstructive cardiomyopathy murmur. All right, we're pretty good now. Mitral valve prolapse is the next one. So with mitral valve prolapse, we got to talk about this one. Mitral valve prolapse. We had the two scenarios here, same thing. We have the normal mitral valve prolapse. There's no change, no maneuvers. And then we have whenever we're trying to drop the venous return. Now remember, what happens in the normal situation is you have, again, eventually the left ventricle contracts, bows the leaflet of the mitral valve into the atria and causes a click. And then an associated murmur, okay? Now, the left ventricle was filled normally in this situation. Now, we're gonna fill it even less. Oh my gosh, I don't even know if I can do this, but you're gonna have a little ventricle right there, a little baby ventricle. Now it's not filled very much. And so because it's not filled very much, it's not gonna take a long time before it actually generates enough pressure to close the mitral valve. Look what happens now to the ejection click. It comes much earlier. If it comes much earlier, now the murmur is much longer, right? It's a straightforward concept now. If the ventricle's smaller, because you're not filling it as much, it's not going to take a long time for it to be able to contract that blood, squeeze it up against to smash the mitral valve closed, in this case, prolapse the mitral valve. So that click will come earlier. So the click will come earlier. Dang markers. The click will come earlier, and then what else will happen? Not only will the click come earlier, but the murmur will be longer. So the click will come early and the murmur is longer. So to quickly summate that, Valsalva standing, you reduce venous return, reduce the intensity of all murmurs with two exceptions. Hypertrophic obstructive cardiomyopathy, you have less venous return, less left ventricular end-diastolic volume, you have more left ventricular outflow tract obstruction because you're not expanding or stretching out that obstruction. You're increasing the intensity of the murmur. Mitral valve prolapse, you're having less venous return, less of that volume of blood in the left ventricle, less time for the left ventricle to contract and smash the mitral valve closed, or in this case, prolapse the mitral valve in, causing the click to come early and the murmur to be longer. And again, think about the little space there. You get a little ventricle, the click has to come early, and now the murmur has to be longer. We done did it. We're almost there. We're at the last part here, which is now the things that change after load. Let's now talk about maneuvers such as the hand grip maneuvers and a drug called amyl nitrate. All right, so we're at the last part, guys. All right, we're at hand grips. What does this do? What the heck does this do? So with hand grips, what you're doing is you're squeezing on something, right? So you're squeezing on something and you're increasing the resistance in the vessels, right? So whenever you do the hand grip maneuver, what this does is this increases your systemic vascular resistance. When you increase resistance, that increases afterload, right? So it's going to increase your afterload. When you increase afterload, it makes it harder for the left ventricle, in this case, we're talking about left-sided murmurs, it increases the difficulty by which the left ventricle has to pump blood out of the heart. So a high afterload actually drops your stroke volume. If you drop stroke volume, you decrease the volume of blood that's leaving the left ventricle. So I'm going to have a reduction in forward flow, you can think about, right? Why is that a particular problem? If I have a stenotic valve, right, I have a patient who has what's called aortic stenosis. Their murmur is louder when there's higher velocities of blood, higher volumes of blood that's flowing across that stenotic valve, right? If there's less velocity and less volume of blood flowing across that stenotic valve, do you think the murmur is going to be more intense or less intense? Less intense. And so it decreases the intensity of that murmur. Okay, good. Next thing. So this will cover this part here. The other thing that you need to remember is that not only a reduction in stroke volume causes less forward flow, but you can think about it the opposite way, is that there is more blood left in the ventricles because I didn't pump as much out. And so if there's more blood in the ventricles, that means that you can think about the ventricles kind of being overfilled with blood because we didn't pump as much of it out. If the ventricles are overfilled with blood, think about what that did to hypertrophic obstructive cardiomyopathy and what it did to mitral valve prolapse. What did it do to it, guys? Well, think about that. If you have more blood in the ventricles for HCM, what did that do? You had more blood, it stretched out the dynamic obstruction. So that decreased the left ventricular outflow tract obstruction, and that decreased the intensity of the murmur. It's not too bad. All right. What about mitral valve prolapse? In mitral valve prolapse, you cause the ventricle to get filled larger, and we could use that diagram to make it easier, right? The more you fill that ventricle with blood, then the click will come later and the murmur will be shorter. You can also think about it as if the ventricle fills with more blood, it's going to take a longer time for it to contract and push all that blood out of the heart. It's going to take a longer time for it to prolapse that mitral valve, so the click will come later and the murmur will be shorter. So in this situation, you'll have the click come later and the murmur be shorter in duration. And the last thing to think about here is actually another condition here, and this is actually kind of a lone wolf associated with it, mitral regurgitation. We never talked about this one, but I want you guys to think about it. In a patient who has mitral regurgitation, think about murmurs in the sense of an increase in blood flow across a stenotic valve or an increase in blood flow or backflow across a incompetent valve causes a murmur, right? So if I have a regurgitant flow of blood across an incompetent valve, what do you think that's going to do to the intensity of that murmur? I have more volume of blood that I can pump against that actual left atria if there's an incompetent mitral valve. It's going to increase the intensity of the murmur. And so this will increase the intensity of mitral regurgitation because I have more blood that's flowing back into the atria across that incompetent valve. Okay, so we know hand grip maneuvers increase afterload, which reduces the intensity of aortic stenosis, reduces the intensity of hypertrophic obstructive cardiomyopathy, causes the click and mitral valve prolapse to come later, the murmur to be shorter, and increases the intensity of mitral regurg. You'd think we'd be done, right? But we're not. Okay. What about the aortic stuff? Okay. In these hand grip maneuvers, again, we increase the systemic vascular resistance. If we increase the systemic vascular resistance, you increase the afterload. We got that down. All right, that makes sense. If you increase the afterload, here's the next way I want you to look at it. Not only is it reducing the stroke volume, but it's causing the pressure in the aorta to be higher, and that's the reason for the lower stroke volume. So you have higher aortic pressures. If there's high aortic blood pressures, then that's okay as long as the valve is functional, right? You'll just have a drop in stroke volume. That's the whole problem, is that normally this will just cause a reduction in stroke volume. But that's if you have a normal valve. If you have an incompetent or leaky valve, guess why that is a problematic issue? If they have an incompetent valve, all that blood in that high pressure vessel is going to flow backwards into the left ventricle. And so you'll have an increase backflow, a regurgitant flow back into the left ventricle. And if that's the case, that will increase the intensity of aortic regurgitation. That's why having high afterload is not a good thing. That's why in patients who have high aortic regurgitation, we actually want to drop their afterload so that they have less of backflow across that incompetent valve. We'll talk about that in this next tip. But to recap, hand grips increase afterload. It does three things. One, reduces your stroke volume, reduces forward flow, decreased intensity of aortic stenosis, causes more blood to remain in the ventricle, particularly left ventricle, stretches out the dynamic obstruction, decreasing HCM intensity, causes it to be overfilled within the left ventricle, taking a longer time to depolarize, contract, and cause the mitral valve prolapse click, which it comes later, and the murmur is then subsequently shorter. And it causes more volume of blood to get pushed across an incompetent mitral valve, causing a mitral regurgitation murmur to be more intense. It also increases afterload, causing the aortic pressure to be high, which isn't a problem if you have a good valve, but if you have an incompetent leaky valve, then you're going to have a massive backflow of blood from the aorta into the left ventricle, which if you have aortic regurgitation, this will just increase the intensity of it. Boom, shakalaka. Okay. Oh, and engineers, before we pass out here, let's talk about the last thing, which is how we can use something to actually reduce afterload, and this is amyl nitrate. So amyl nitrate is a drug, and what this does is it'll cause vasodilation. Okay, so it'll vasodilate. Just like whenever you do hand grips, you vasoconstrict, which increases the systemic vascular resistance, right? So hand grips just cause vasoconstriction. So if we were to write that down here, hand grips, all they do is they cause vasoconstriction, and that increases systemic vascular resistance. With amyl nitrate, you vasodilate, which does what? It reduces systemic vascular resistance. If you reduce systemic vascular resistance, that reduces your afterload. If you reduce your afterload, you increase your stroke volume. If you increase your stroke volume, you increase your forward flow. This is going to be so easy now, guys. If you increase your aortic flow in a patient who has aortic stenosis, that means that more blood flow, more velocity is flowing across that aortic valve. If more blood is flowing across that stenotic valve, you're going to have an increase in the intensity of that murmur. Boom. If you have a higher stroke volume, that means that you have a decreased volume of blood in the ventricles, remaining in the ventricles, because you're ejecting all of it out. If you have very little blood within the ventricles, what did that do to the HCM? It's the exact opposite now, right? So for hypertrophic obstructive cardiomyopathy, it's going to cause what to the left ventricular outflow tract? Well, you have less of it to stretch it out. That's going to increase the left ventricular outflow tract obstruction, and that's going to increase the intensity of that murmur. Boom. Mitral valve prolapse. You're going to have less volume of blood in the ventricle. Think about that little diagram. Little filled ventricle is going to cause the click to come early and the murmur to be longer, or you can think about it being underfilled. It's not going to take a long time for the ventricle to contract and prolapse that mitral valve, causing it to come early and the murmur to be subsequently longer. So the click will be early and murmur will be longer. Next is, again, if you have someone who has mitral regurgitation, you're going to have less volume of blood in their left ventricle. If there's less volume of blood and they have an incompetent or leaky mitral valve, that means that they can cause backflow into that area, but there's less volume of blood, less velocity of blood flow across an incompetent valve. That means it'll decrease the intensity of that murmur. So in this situation, you'll have a decrease intensity of the mitral regurgitation. Oh, we're at the last part. In this last situation, again, we think about amyl nitrate. Again, it's going to reduce systemic vascular resistance. We can look at it in the sense of increasing stroke volume, right, via the reduction in afterload. But the other way we can look at this is low systemic vascular resistance lowers your afterload. And what did that do to the aortic pressure? Because again, afterload is the pressure that the left ventricle has to overcome to push blood in the aorta. If the aortic pressure is really high, that means that the afterload is high. If the aortic pressure is low, that means that the afterload is low. So it's going to lower the aortic blood pressure. If you have a competent valve, so if there's a competent valve, what will that do? That'll increase your stroke volume. But if you have an incompetent valve, if you have a competent valve, that's not going to be a problem. Blood won't backflow, and you'll be able to maintain a good stroke volume, okay? But if you have an incompetent valve, there may be some type of backflow if there's an issue there, right? So if you have an incompetent valve, that could be an issue, right? There could be backflow, but if you compare this to this situation where there was a high afterload, high aortic pressure, that means this pressure in this aorta is dang near high, and it is going to flood down into the left ventricle. Blood is going to flood down across that incompetent valve, causing an intensity of that murmur way, way more intense. If you have a low afterload, low aortic pressure, the incompetent valve, even though it is present, do you think you're going to have as much backflow if the pressure in this aorta is lower? Will you have as much backflow? No, because the pressure is lower because you're going to be pushing a lot of blood out. And there's going to be less of that regurgitant flow back into the left ventricle. And so this will reduce the backflow. And if you reduce the backflow, you reduce the intensity of the aortic regurgitation murmur. There's going to be less pressure in the aorta, and if there's an incompetent valve, there's going to be less backflow. Because if there's high pressure, it's going to want to go to areas of low pressure, right? But if there's not as much high pressure in this area, there's not going to be as much blood backflowing into the left ventricle. As compared to this situation, there's high afterload, high aortic pressure. That's high pressure to low pressure. Tons of blood will flow back into the left ventricle because it's in a high pressure system to a low pressure system. Here, you drop the afterload, you drop the aortic pressure, not as much high pressure to low pressure, less backflow, less regurgitation and aortic regurg. Ninja Nerds, before I pass out, I thank you guys so much for sticking along with this video with me. I hope it made sense and I hope that you guys enjoyed it. As always, until next time.